Good day, everyone. Welcome to the webinar, Telehealth Updates and Best Practices Amid COVID-19. As I'm sure you know, online access is being used more than ever during this time, and so the quality of the presentation may be strained at times. If you're experiencing sound or technical issues, please comment in the chat room and I will address it after I am done talking. My name is Angie Fiedler-Sutton, and I'm with the Behavioral Health Association of Providers. The Behavioral Health Association of Providers, otherwise known as BHAP, is a national trade membership association that provides education and advocacy for behavioral healthcare providers and related entities. Formerly known as the American Addiction Treatment Association, BHAP is the leading and unifying voice of addiction-focused treatment programs. We provide membership benefits such as networking and access to compliance information, educational opportunities such as this webinar and our Certificate in Addiction Treatment Marketing, the CATM, and advocacy efforts to keep those in the industry aware of new laws and regulations that may be coming that will affect them. Working in the behavioral health industry or managing an organization in the industry can be incredibly complex and filled with ever-changing information. BHAP gives you resources to stay on top of the rules and regulations for your organization to stay compliant. For more information about BHAP, you can visit our website at www.bhap.us. Before we begin the webinar, a few housekeeping details for those of you joining us for the first time. You will be able to hear us, but we won't be able to hear you. That's because we record these webinars, so you have access to them later if you need them. However, if you have questions or concerns, you can use the chat room on the lower left. You don't need to wait until the end for questions. We will be moderating them as needed. We will send a link to access both the webinar and the PDF of the slides via email after the event. Before we introduce our speaker, I wanted to present some best practices and tips for working in the virtual space and presenting. I have a theater background with over 20 years of experience working with arts organizations. I've planned several events throughout the years and have a master's in specialized journalism, where one of the things we focused on was how to best use technology to get information across to an audience. I also produce a podcast and have done both audio and video production. Tips and tricks. First of all, the technical side. Familiarize yourself with the software that you'll be using, whether it's Zoom, webinar, GoToMeeting, Google Hangouts, or whatever. If it's something that you're not familiar with, make sure that you are familiar with it. Read the about us. Make sure that you see how it interacts with your computer, how it needs to use access to your webcam, whatnot, and all that. Second step is know your own tech and knowledge. This means, make sure you know how your headset works, how your microphone works, how your webcam works, how it interacts with the browser, which browser works best with the software, and make sure that you're using headphones if you're doing any kind of Zoom thing, because obviously if you don't, you're likely to have an echo effect because the other participants will be able to hear your speaker. Also, if you're not tech savvy, listen to those who are. Ask questions of the people who are doing the event prior to the meeting. Test it out if you can. Kristina and I, for example, did a test webinar run through the other day so we could make sure that we could test our audio and whatnot. And then, make sure to have a strong internet connection, direct wired if possible. Technology is technology, and we'll be skittish on a weaker connection, with the gap even worse now that everyone is moving online. Finally, on the technical side, things are going to go wrong, as you've been hearing. So make sure you're flexible. Have a backup plan. Have various information in place. Make sure if it's something that needs to be accessed later, that you are recording it. Also, be sure to have security in place. If you're doing something, for example, that involves telehealth, you're going to want to make sure that whatever software you're using has security in place and follows the proper procedures. There's some articles I'll include in the links that I send out that include how to have a secure meeting. But yeah, something's bound to happen. Be flexible, work with it. Now onto the presenting side, if you're going to be a presenter. First of all, the presentation itself. Obviously, as you can see on my slides, I only have a very brief list of what I'm talking about. That's because people tend to read what's on the slides, and so if you have the whole thing there and you're just reading the slides, people will tend to tune out what you're actually saying. Make sure that the graphics are visual, like you see here. Make sure that it's engaging and whatnot. There's a great PDF download from Andy Goodman at the Goodman Center that I'll include that I've been recommending for years that's called When Bad Presentations Happen to Good Causes. Now, it's primarily geared towards nonprofits, but it can be transitioned to everything. And it's basically how to use PowerPoint effectively and for effective storytelling. Second, the video webcam specific. If you're doing a webcam, like at Zoom meeting, make sure your virtual space matches the event. Now, notice I said make sure it matches, not to dress up or whatnot, because it depends on the event itself. You're going to be doing, say, for example, an AA meeting, you might want to be a little more casual than if you're doing, say, a meeting with prospective customers. So that also includes you, how you're dressing, whether or not you wear makeup, your background. That's, for example, if you're doing a webcam, you want to make sure your background is well lit, as well as that what you have in the background, you don't have, it looks however you want it to look, that you don't want to have, for example, a bunch of stuffed animals if you're going to be presenting to professional people. There is a great video from the YouTube celebrities, the Vlog Brothers, John Green, on how to do video chats, and I'll include that link as well. It includes how to do lighting, how to make sure your camera's set up correctly, all that stuff. It's a great video, and it's about 5 minutes long. Finally, I'll finally be comfortable with what you're presenting. Be aware where you are in relationship to the mic. If your mic is not connected to a headset, make sure that it's what they call, what we call in the industry, ice cream cone length, basically where you would put an ice cream cone. Because obviously if it's too close, you're going to get feedback, and if it's too far away, you're going to have people not hearing. Beware of external sounds. For example, in today's day and age with working from home, you're going to have garbage trucks outside. You're going to have the lawnmower outside. You're going to have people in the next room. You're going to have all sorts of distractions. Make sure that you're aware of that. Mute yourself when you're not speaking so those don't interrupt other people. Also, be very familiar with what you're presenting. Make sure that you've gone over it a couple of times, that you're familiar with it, so you're not left struggling with what to say next. And finally, be aware of the time. And a lot of these events have a very specific time length, and you want to be conscientious to make sure that you're using the person's time valuable of the people who are listening. And with regards to being comfortable with your presenting, just to remember that not everybody learns or participates in the same way. Obviously, presenting online and being online is very different from being being in person. People learn differently. If it's some sort of public event, make sure that there's some sort of moderation in place and give people time to ask questions. Not everybody wants to ask during the event. They want to be a little bit more at the end. Some people are a little bit more nervous. And then check in occasionally. Being online is different from being in person in terms of that you don't necessarily see the people that you're interacting with, or that they're going to be much more distracted by other things in there. So make sure that you every once in a while check in with the people you're talking to, that they are still paying attention, that they're still in there. Now, if they're not, don't take it personal. We're all going through a stressful time, and they just might have a lot of things on their plate. But make sure that everybody's on the same page. And then if at all possible, make sure that the event is accessible, not just in terms of technology, but in terms of try and have captions available for recordings. If it's going to be a video presentation, try and see if you can find somebody to do sign language to help those who may be of hard of hearing. And then my final tip, have fun. This is a difficult time. Cats and family members are going to inevitably interrupt. You'll notice that this sounds differently than the rest of the presentation. That's because on the initial recording, I lost the internet during the presentation. Things are going to happen. Be flexible, have fun, people are going to understand. And now it's my pleasure to introduce our presenter today. Kristina Sherry is a transactional and compliance attorney with Nelson Hardiman. Kristina brings to her healthcare practice the equanimity of a litigator and experience defending public entities such as the Los Angeles World Airports and the Los Angeles Unified School District. She advises hospitals, physician organizations, long-term and behavioral care providers, and other health-related organizations in transactions and regulatory matters. Kristina, thank you for taking the time to present today. With that, I will hand the webinar over to you.
Getting into the presentation. So my name is Kristina Sherry. I'm an attorney at Nelson Hardiman, and I have done some work in telehealth. So we thought we would put together kind of, a summary of what's happened in the past just month and a half since the pandemic happened. So getting into disclaimers first, this webinar is for educational purposes only, and it's not meant to be legal advice. And any individual or entity considering what to do with the information in this webinar should consult an attorney for their particular situation. That said, if there are, if anyone has specific questions, you can type them in or email me afterwards, and I'll try my best to get you an answer. But this presentation is pretty general, although it is California centric, because that's where we are, and we give the caution that telehealth laws are very state specific. An important additional disclaimer, especially during this time, is that because we're looking at a lot of the emergency responses to the pandemic, this information is current as of today. Some of the slides we made last week might have even been updated further. So please visit the relevant authorities' up-to-date guidelines and websites for the most current information. So to give some background before what telehealth framework looked like, as early as February. So which authorities were in charge of kind of putting the restrictions on what we could do with telehealth? The authorities in charge of making that framework were largely state laws and regulations and professional licensing boards. And in California, certainly, and in other states, healthcare professionals can be disciplined for not meeting the standard of care when they're using telehealth. And we'll talk a little bit later what that means, or not following up with patients properly. So that comes a lot from state laws. The definitions of telehealth vary greatly by state, but in California, for example, telehealth is defined as the mode of delivering healthcare services and public health via information and communication technologies to facilitate the diagnosis, consultation, treatment, education, care management, and self-management of a patient's healthcare. So it's pretty broad. And the definition also says that telehealth facilitates patient self-management and caregiver support for patients and includes synchronous interactions and asynchronous store and forward transfers. So again, it's pretty broad. This is in California's Business and Professions Code. And it also defines what is meant by, talk about synchronous versus asynchronous telehealth. And asynchronous store and forward in California means the transmission of a patient's medical information from the originating site, which is where the patient is, to the healthcare provider at a distant site. And synchronous interaction, as you could probably guess, means real-time interaction between a patient and a healthcare provider at a distant site. In addition to state laws and regulations, payers have their special requirements about what the provider needs to do in order to get reimbursed for telehealth. And oftentimes that includes a consent requirement, and we'll talk about that more later. Or before the pandemic, certainly there were special requirements about where the patient needed to be located. But as we'll see, a lot of these requirements have been loosened. And then, of course, there's federal and state privacy and security laws. HIPAA is the first one that comes to mind. And then states kind of have their versions of HIPAA, sometimes called mini HIPAA. In California, it's the California Medical Information Act, or CMIA. And then finally, if the provider is prescribing medications, there's laws that require, that have certain requirements for what needs to happen if the prescription is to be given over telehealth. And there's a big federal law we'll talk about shortly. And together, these authorities make restrictions with respect to the standard of care, informed consent, the kinds of documentation the provider needs to have, the specifics of the platform being used, whether it's audio or telephone only, and then, as we talked about, the originating and distant sites, and that's where the provider and the patient are. The originating, the patient, distant site is where the provider is. The standard of care, and this is something that has not changed during the pandemic, a major tenet of telehealth is that the standard of care is the same whether the patient is seen in person, through telehealth, or other methods of electronically enabled healthcare. And you'll find this on the California Medical Board website. This is a really important tenet of telehealth. And it goes on to say that the use of telehealth shall not alter the scope of practice of any healthcare provider, and providers keep the same duties associated with practicing medicine that they would have in person. Informed consent, this is a specific requirement found in California's law, the Business and Professions Code. And so what it requires providers under most circumstances to get verbal or written consent from the patient they're seeing by telehealth. So what are they consenting to? It doesn't specify, but generally we recommend that an informed consent document would specify the type of treatment or the condition generally. Is it group versus individual therapy? Just so the patient knows what the telehealth is for. Acknowledgement of limitations of telehealth. Obviously, it's not the same as in person, so you want to include an acknowledgement of that. The acknowledgement for potential technology failure, we've seen that today. So we can imagine what would, that would be, worse. This is just a webinar, but that would be worse in instance of telehealth. Acknowledgement of confidentiality risks, particularly with third parties. But we'll talk about HIPAA later on and how HIPAA has relaxed some of its standards. Acknowledgement of the patient's responsibility, that they're expected to show up and log in on time, and acknowledgement of alternatives to telemedicine that are available. In person is an alternative, more so when there's not a pandemic. And then it usually includes an authorization regarding disclosure of health information. And as we'll see later, California's emergency order waives this consent requirement during the pandemic. But for reasons we'll discuss later, it's still a good idea to obtain informed consent when possible. And then, as we just looked at this statute says that the consent must be documented in the medical record, even if it's just obtained verbally. And telehealth doesn't waive any requirements with respect to, updating the patient's medical record appropriately. And it's good to confirm payer requirements. Many payers have specific attestation for healthcare providers. We'll talk more about that later. So we looked at the definition of telehealth in California. It's important to remember that those definitions vary widely. They may vary by payer, or when we think about what telehealth is in the context of privacy and security. So it's always good to look at those definitions and see what it encompasses. And as we also looked at, California considers telehealth to include both synchronous, which is the real-time interaction, and asynchronous, which is the transmitting something from the patient to the provider, as well as hybrid forms like interactive audio, combining the telephone with some kind of data review. So that would be a hybrid model. And then synchronous can include telephone only, but certain authorities, for example, in prescribing, which we'll look at shortly, do require video, but synchronous can include just telephone. So some quick background on prescribing. A big federal law to consider is the Ryan-Haight Online Pharmacy Consumer Protection Act of 2008, and this law was passed in response to abusive practices, physicians using questionnaires, very general questionnaires to provide medication, and physicians not even meeting the patients in person. And as a result, it regulates online internet prescriptions and controlled substances prescribed by telepsychiatry. And this is a law that's enforced by the DEA. Again, this is also something that has been relaxed amid the pandemic. We'll look at that. And the Act generally requires in-person medical exam before prescribing medications over the internet. And there are some exceptions to this, one of which is the public health emergency. So the DEA has confirmed that this does in fact meet that COVID meets these requirements and has relaxed some restrictions accordingly. So we'll quickly look at the declarations and changes that have happened that has allowed certain requirements to be loosened with respect to telehealth. So in December of last year, a new virus, a new coronavirus was first detected in China. And it's important to distinguish that coronavirus is the virus and COVID-19 is the disease that's caused by the virus. And some publications still get this wrong. So if you want to be extra correct, that is the correct distinction. At the end of January, the Health and Human Services Secretary declared COVID a public health emergency, which was retroactive to January 27th, under the Public Health Service Act. In March, WHO declared it a pandemic, and then later in March, President Trump declared a national emergency. And this, along with the declaration of public health emergency, can allow the Health and Human Services Secretary, AZAR, to take certain actions, including Section 1135 waivers, which we've seen with Medicare. And we'll look at that later. So looking at states, a bunch of states have made declarations as well, focusing on California. On March 4th, Governor Newsom declared a state of emergency. And on April 3rd, he signed an executive order to expand protections for providers using telehealth. And some important elements of this order were that it suspended the informed consent requirement under the Business Imperfections Code, which we discussed, with the caveat that we still recommend informed consent. And it relaxed privacy and security laws. And this kind of mirrored some of the changes that HIPAA had announced. And we'll get to those later. Such as by suspending certain penalties for privacy violations under the CMIA. And importantly, the order explicitly stated, and twice it mentioned, that these protections do extend to behavioral and mental health services. When it specifically said telehealth services includes the use of telehealth services to engage in the provision of behavioral or mental health services, in addition to medical, surgical, or other types. So that was probably the most important state order, or most relevant to this discussion that we've seen for telehealth. And we'll just take a quick survey of some of the federal responses and see what these have allowed. Generally, the CDC has promoted expanded use of telehealth and encouraged the use of telephone visits even where formal telehealth systems aren't available. One important thing that kind of got buried in has gotten buried in other news is that the CARES Act provision, the CARES Act has gotten the most attention for the stimulus checks, most likely, but included in the CARES Act were changes to Part 2, which is the statute governing, or the regulations carrying out the statute governing confidentiality of SUDS patient records. And the amendments include greater protections for patients by more strongly limiting their use of their medical records in civil, criminal, and other contexts. But they bring the disclosure requirements more in line with HIPAA and make it easier to redisclose patients' that information for treatment, payment, and healthcare operations purposes. And this, in the provisions of the Act, it gives HHS 12 months to write the regulations, to revise the Part 2 regulations that will make these changes. And we'll be following that and provide some updates on how those Part 2 regulations are going to change. But this kind of did get lost in the news because there's so much else to focus on relating to COVID. SAMHSA itself has stated during this public health emergency that it has advised that outpatient services be used whenever possible. And its many SUD treatment offices are closed. They recommended the use of telehealth or telephonic services in accordance with those general CDC guidelines. And they said that these telehealth services can be used for initial evaluations, including evaluations for consideration of the use of buprenorphine products to treat opioid use disorder. And they can also be used to implement individual or group therapies, such as evidence-based interventions, including cognitive behavioral therapy for mental and or substance use disorders. So that is SAMHSA's commentary. Oops, sorry, I realized we mixed up the acronym there at the top. So in March, around this, even before HIPAA announced some relaxation of HIPAA, or the OCR announced some HIPAA relaxation, SAMHSA had published guidance on the prohibitions on the use and disclosure of patient identifying information under that Part 2. And they didn't exactly relax the rules, but they did note that the prohibitions on disclosure do not apply when there's a medical emergency. And it didn't explicitly state that that COVID was a medical emergency, but it did emphasize that under the medical emergency exception, providers make their own determinations about whether emergency exists for purposes of providing needed treatment. And require that, or remember, amid this, that Part 2 requires programs to document certain information in their records after disclosure is made pursuant to the medical emergency exception. And then from the previous slide, we know that these regulations will be getting changed in the next year. So we'll keep an eye on that. So the agency, the HHS oversees HIPAA, and within HHS, there's the Office of Civil Rights, and they enforce HIPAA. Under normal circumstances, HIPAA rules require specific security safeguards for electronic protected health information at rest and when it's in transit. And so what this means is that if there weren't a public health emergency or under normal circumstances, a lot of the platforms we're using today for, just office chats and now, those wouldn't really make the cut in terms of meeting HIPAA's security standards for telehealth. However, on St. Patrick's Day, OCR issued a notice that it would not impose penalties for noncompliance with the regulatory requirements under these rules in connection with, and this is important, the good faith provision of telehealth as long as this public health emergency is going on. And they specified that the types of technology they would allow would be non-public facing remote communications products. And so we do, it's not all security rules are out the window. You still need to be using telehealth in good faith. It has to be during the pandemic, and the platform still needs to be non-public facing. So what does that mean? HIPAA described a non-public facing platform as one that as a default only allows the intended parties to participate in the communication. We've heard a lot about Zoom bombing, and there's just more open platforms. And so as examples, they said platforms that would likely be acceptable would include Apple FaceTime, Facebook Messenger, video chat, Google Hangouts. I didn't realize some of these were that secure. WhatsApp video chat or Skype. And they said things like Facebook Live and Twitch and TikTok, which are designed to be, meant to be open to the public, are not acceptable. Another important limit of this is that it doesn't let providers off the hook if there's a breach. So if patient information were to be exposed, providers are still responsible for reporting it and just the cleanup costs associated with a breach. And of course, providers also are responsible for complying with state laws and payer requirements. And during this pandemic, OCR doesn't necessarily require the providers to be in their offices providing telehealth, but they still need to be they're still expected to be in a private setting. And also with the good faith, if you can look at the notice for more information about what they're allowing here, but good faith obviously means not using it to commit a crime, medical necessity. So you can see more specifically what they mean by good faith. It's probably common sense. The DEA has also responded to the pandemic, and following the public health emergency declaration, they announced it would allow DEA registered practitioners to issue prescriptions for controlled substances to patients for whom they have not conducted an in-person medical evaluation, so long as a handful of requirements are met. And these include the fact that the public health emergency is still going on. The prescription is for a legitimate medical purpose by a practitioner acting in the usual course of his or her professional practice. So again, it needs to be within their scope of practice and something that they would normally do. And this is important, the telemedicine communication is conducted using an audio-visual, real-time, two-way interactive communication system. So here they're specifying audio-visual, synchronous, here store and forward won't cut it, and the practitioner is acting in accordance with other federal and state laws. And regardless of these new rules, a prescription for a controlled substance must always be issued for a legitimate medical purpose. So I know maybe this audience isn't so interested in, Medicare isn't so relevant to this audience perhaps, but it's always good to look at what CMS is doing because they're often a baseline and a guide for some of the private payers, and they kind of set the trends in this area. So significantly, CMS has relaxed certain requirements with respect to telehealth, and this is good to look at as we'll look at the private payers after this. So before the public health emergency, CMS coverage was coverage of telehealth was mostly limited to designated rural areas and a few certain other settings. But around the same time as the OCR HIPAA announcements, the CMS announced that telehealth would be covered temporarily under the Section 1135 waiver. And that's something that happens when there's a public health emergency and the national emergency declaration. And Medicare, under these circumstances, can pay for office, hospital, and other visits furnished by telehealth across the country, including patient residences. And they even made this retroactive to March 6th, 2020. And they specify that providers can include clinical psychologists and licensed clinical social workers, and it applies to telehealth visits, virtual check-ins, and e-visits. The latter two, I don't have those definitions, the formal Medicare definitions of what a virtual check-in versus e-visit is, but those require an established relationship before telehealth can be covered. Because sometimes we get a lot of questions about whether there has to be the patient-provider relationship before they can do telehealth. And Medicare generally requires synchronous real-time interaction for coverage. And Medicare, in addition to the initial waivers with Medicare, they also have relaxed certain supervision requirements. Again, this isn't relevant to this presentation so much, but in certain rural hospitals or critical access hospitals, they're allowing the physician to remotely supervise, some of the nurse practitioners or PAs where the physician would normally be required to be present in person. So getting into the private pay, this is important. We had a BHAP presentation entirely on this subject last week, so you can go back and look at John Mills and Zach Rosenberg's presentation about getting reimbursed. But just to do a quick version of it, California's Department of Insurance, Healthcare Services Administration, and managed healthcare agencies, they've all issued guidance to their regulated insurers and plans, generally requiring, broadly speaking, that telehealth reimbursement mirrors in-person, again, so long as it's clinically appropriate. And many payers impose a consent requirement, as we've discussed, and attestation requirements. And one of the big ways in which they've relaxed requirements is with respect to the patient and also provider location. So previously, they would have certain requirements about where the patient needed to be located, and a lot of those have been relaxed during this time. But it's still essential to verify coverage and get and obtain authorization wherever possible before providing the services. So the next slide that we'll look at kind of illustrates what we're talking about at the bottom, but it's good to confirm, some things you want to look at when verifying coverage is which services are covered. And as we'll see on the next slide, many will cover PHP, IOP, OP, some of them not all three. So we'll look at the most recent chart. The time frame, Medicare made its coverage retroactive to March 6th. So you can look at when they started covering those services, and also keep in mind an end date. I know for HIPAA and for HIPAA, certainly, they're saying that their rules will be relaxed until they declare until they say, the relaxation of rules no longer applies. Presumably it's as long as there is a public health emergency, a national emergency, but be sure to stay on top of when these relaxed rules are return to normal, if they do. And at the end, we'll talk about whether some of these changes may be here to stay. You also want to look at the permitted sources or platforms, video conferencing security, certain platform requirements, and then again, the location of the patient and provider. And also in the guidance issued by the Department of Insurance and the other agencies, they've reminded providers and insurers that on which modifiers can be used. So O2 is generally used for place of service, indicating a distant site for the provider. And then modifier 95 is used for synchronous, and GQ is used for asynchronous when submitting for reimbursement. So again, this may have changed since we made it into a slide, but this is a nice kind of little chart of what some of the private payers are doing, which services are covered. You'll see on the left column what time frame. Some of them have already said this will be through June. The platform requirement, where it says source, location of clinician, as you'll see here, this is where a lot of these location requirements are getting waived, and then some other notes about requirements. But you should go directly to the payers' websites and check for the most current information. So a big theme of this presentation is that even though many of these requirements are getting relaxed, it's still, a lot of those rules were there for a reason, and it's still a good idea to try to follow them whenever possible. We're talking here about ethics because relaxed rules often invite fraud and abuse issues. For example, payers may forgive missing documentation, or later they could treat it as a basis for denial of payment. Our managing partner, Harry Nelson, gave a presentation in March about telehealth, and he made a good point that whenever there's a relaxation of rules such as this, it tends to become a fraud and abuse issue about a year later or so. So it's important not to go beyond what these rule changes are allowing. And again, certain waivers require good faith use of telehealth. They always require medical necessity and that the provider meet the standard of care and doesn't go beyond his or her scope of practice. And then again, consider what a part of that standard of care consideration is whether telehealth is appropriate. In some cases, it's not. And if providers are under the umbrella of essential services, there could be instances, although we're discouraged from meeting in person, there could still be instances where meeting in person is more clinically appropriate than remote care. So tied along with ethics is best practices. Again, really consider whether telehealth is clinically appropriate for the treatment or patient. Sometimes it's not. Obtaining and documenting consent is still advisable, even though the California order, for example, is waiving the consent requirement during this emergency. And think about other issues presented by telehealth. If some best practices, whether or not there's a public health emergency, include confirming the patient's identity, whether that's having them hold up an ID or any other method, documenting the originating site, that is, again, where the patient is, appropriately documenting care in the medical record, be familiar with appropriate referral sources when providing telehealth, and then related to that, establish an emergency plan if the encounter is disrupted, for example, by a tech failure. What will you do in that case? And then notify the patient or ensure the authorization if the encounter is being recorded. So this is a lot in line with this has to do with HIPAA and privacy and security regulations in particular, but it's still a good idea to have the provider to sign a business associate agreement, which is a HIPAA term you're probably familiar with. It's even if, technically not, it's still a best practice to have the provider sign the BAA. And as we've talked about Zoom bombing, so beware of video teleconference hijacking, as they're calling it. And these requirements here, these guidelines here come from FBI guidance about Zoom bombing and this hacking. And the FBI has recommended ensuring that meetings are private, either by requiring a password for entry or controlling guest access from a waiting room. Consider security requirements when selecting vendors. For example, if end-to-end encryption is necessary, does the vendor offer it? And then, of course, ensuring that the software is up to date. Groups like Alcoholics Anonymous have shifted to teleconferencing. And AA's General Service Office, it's not an authoritative body, tells them what to do, but it has encouraged groups to use whatever platforms meet their needs. And, for example, groups have used platforms including Zoom, Google Hangouts, Meet, and free conference calls. So a big question, you'll see a few articles about this these days, and I've heard some radio discussions about this. As we've had this relaxation in telehealth rules, will some of these changes be here to stay? Now, I've certainly had friends say, oh, it's so nice to just make a call or do this, and providers certainly like the ease of it too. And we are indeed at a watershed moment where services that can be shifted to telehealth have shifted, and many people are preferring this efficiency and convenience, and seeing more, and providers can see more patients with less effort and overhead. Teladoc, for example, reported onboarding thousands of new physicians in a few days at the beginning of the crisis, and previously had been, it'd take a couple of months to get that many providers on board. And CMS administrator has even sounded open to potentially keeping some of these changes permanent for Medicare that would require an act of Congress. And previously, there had been resistance because, again, it is easier it does invite fraud and abuse issues by providing this reimbursement with these relaxed requirements. But again, the CMS administrator hasn't ruled out that some of these changes could stay. But in the meantime, it's important to keep an eye on what the agencies are saying. When the OCR declares that the HIPAA relaxations are no longer, or keeping an eye on the payer requirements and always checking the requirements and seeking authorization. So some other resources, this might be helpful because, again, this was very California specific, and some people might be from other states. The TALK website here is really great and up to date. You can select the state, you can select what you want to look at. We talked about provider location, whether they have to be in that state or any other type of location, payer requirements, platforms, whether the state considers asynchronous to be telehealth. This website just takes all those elements and pretty much answers any questions you have about a certain state. And I believe they do have the updates. They acknowledge the updates that have occurred during COVID. So the Center for Connected Health Policy is a good state-by-state website. The CMA, California Medical Association, just has a really great up-to-date tracker on what's happening with all things COVID, and they even have some FAQs specific to, they sort their FAQs by category, and they have some specific to telehealth, and they're updating those every day. So that's another great resource. Just SAMHSA coronavirus guidance generally. HIPAA's updates, you can check. The OCR has a specific COVID section, and then the California Department of Public Health also has good COVID updates. They're pretty up to date. So that concludes the presentation, a little bit early. Again, if anyone has questions, even if not now, I can look into them and answer them later.
We did have a few questions you may or may not have answered since I was out for part of it, so just feel free to reiterate that you've already answered it. John said, thank you for referencing standards of care. One of the questions I've struggled with when consulting is the extent to which initial evaluations of patients can be done over the telephone. It's clear standards apply with video visits, but thoughts on this with telephone and how you considered standards?
Oh, yeah, no, that's a good question. It would be state specific, and I would suggest, I don't know if John is a California provider, I would recommend looking at the medical board website and seeing if even CMA, I think it's possible CMA has a FAQ addressing that. And it would, it varies by patient and situation, of course, as well. But I think the medical board website or the CMA's FAQs about telehealth should address that somewhere. But that's a very good question.
And then we think this was already answered, but Tamara was asking, will there be specific information related to protections for SUD assessment and treatment?
So we talked about some of SAMHSA's just general response to the emergency and the fact that the CARES Act will include a statutory change for that will result in changes to Part 2. I think we'll probably try to do a specific article about those changes, and we can get more into that. I don't know if this answered the specific questions she had, but I can try to answer, a specific question later.
Okay. Any other questions, please put in the chat room while we're waiting to see if there's any others. I do want to thank Kristina Sherry for presenting today. Thanks as well for everyone in our audience for participating and dealing with our tech issues. As I said, a reminder that a link to access both the webinar and the PDF of the slides will be sent probably next week from an email ending with bhap.us. Please sure to keep an eye out for it. Well, we hope that you will join us for future BHAP webinars. You can sign up for our various newsletters, which include emails specific to upcoming events at our website, www.bhap.us. We are also keeping a list of resources related to COVID-19 on our website, including other webinars dealing with this issue. If there are no further questions, looks like not. This concludes today's webinar. Thank you very much.